What happens when your body starts surprising you? How do you begin to understand what's happening and what to do next? Welcome to How We Really Feel, the podcast that explores how your biology, psychology, and social experiences shape your physical and mental health. I'm Dr. Sula Windgassen, a health psychologist, academic researcher, and author. Each season, we'll go deep on a different health experience through a biopsychosocial lens. And this season, we're diving into the bladder and pelvic health. We'll cover everything from whether there is such a thing as breaking the bladder seal to how interconnected your bladder, bowels, and pelvic floor nerves really are. Every episode is built on credible expertise, guests chosen for their clinical knowledge and lived experience, with references and resources discussed in episodes linked for you to access. Because when you understand how you really feel, you can start to feel better. In this podcast, we explore how bladder and pelvic health is influenced by so many things, including what you think, how you feel, and how you respond to your body. That's why I jumped at the opportunity offered by Convatec to develop a free-to-access, holistic wellbeing program open to the several million people who catheterize intermittently. This completely free program explores specific bladder and catheter-related concerns, the impact on life, sex, and well-being, and offers you a way to live life with confidence. Designed for intermittent catheter users and open to those navigating the journey, as well as those who support them. You can access it by checking out the show notes. In this episode, I was joined by Sachin Malde, consultant urologist, specialising in functional female urology, bladder pain syndrome, and chronic urinary tract infections, and Clare, pelvic and digestive health physiotherapist, specialist in biofeedback, and author of Strong Foundations. We covered everything from whether there is such a thing as a normal bladder, habits that you might have that can actually change the physiology of your bladder and your pelvic floor, and everything that you need to know when your bladder starts acting out of the ordinary. This episode will help you understand what is happening when you get that urgent need to go, why you get urinary tract infections, and the down low on UTI testing. We also spoke about the overlap between the bowels and the bladder and why what started your UTI might not be what keeps it going. I hope you enjoy this episode. It's really lovely to have you both here. I'm very excited to be discussing all things to do with our bladders. What's normal, what's not normal, when things go wrong, what happens as a consequence of that, and what we can do about it. I'd love you to introduce yourselves, first of all. So starting with you, please, Sachin.
Yeah, well, thank you, Sula. It's great to be here. So I'm Sachin Malde. I'm a urologist. So I focus on men and women's kind of bladder health. But my specialist interest really is in bladder conditions. Bladder conditions, but bladder pain, infections, and incontinence. It's kind of the main areas I've been focusing on over the last few years.
Yeah, we're really excited to have you here because of that, exactly. And Claire?
Oh, thanks for having me as well. I'm Clare. I'm a specialist pelvic health physio, so I work with women, men and children, so anyone of any age with anything relating to the pelvic floor. So it might be bladder, might be bowel, might be sexual health conditions. And I've just got a real passion for, I guess, the more complex case where maybe things have been going on for a long time, understanding just more about the individual sort of biopsychosocial model that I know you're very passionate about, and sort of working with an MDT to work out how can we all bring together to provide best care.
Fantastic. And I'd love maybe just to start off, because when I'm working with my clients, like you say, Claire, often it's kind of complex presentation. So things have been going on for a while. It's not been straightforward. Actually, a lot of people in my clinic tend to be younger, and they tend to think I'm the only one that's having this kind of issue. And from these discussions, it's come to my attention that I think maybe the general public has an idea of who gets bladder issues and what that looks like. I'd love to hear your thoughts and kind of demystify who are the people that get bladder issues.
I'll go for it. Yeah, I mean, you get that so much in clinic. I get a lot of women being like, do you just see postnatal women? And I'm like, no, I see everyone of every age. And actually when you say children, they're like, what, children? And I think that's what, anyone who's got a bladder can have a bladder symptom at any point in their life. And I think, I think sadly it's become a sort of more, menopausal, postnatal, because that's been more talked about. I mean, we weren't talking about anything for a long time, so we've done well to get that into the mainstream conversation. But I think you're right, women can still feel, or men or children can feel very alone, thinking, this doesn't mean anything for me. I mean, most people don't even realise they've got a pelvic floor until they maybe have a baby. So for me, the conversation's like, well, let's start there. But yeah, anyone of any age can be impacted. We all have an organ of a bladder, so it can impact us at any age.
Yeah, no, I completely agree. I see. We same thing it's kind of a myth that people often think this is just an older person's condition, older men, older women. And you see them in clinic and they say, I must be a bit unusual, at my age. But actually, we see people who have had problems from childhood that then carry on into late teens, early 20s, and have problems throughout their life. So I agree. It's exactly like you say, it's a problem for all ages.
And just thinking about that bladder issues starting at childhood, could you shed some light on why these things might start in childhood? I'm sure there's many varied reasons.
Yeah, we see a lot of stuff being related to the bowel, so maybe constipation that starts and then that impacting, because within the pelvis everything is very, very close together, though a lot of our anatomical diagrams make it look like they live in separate villages. They're actually right on, they're very, very closely connected. So, we know constipation is rising in children, and then that can actually lead to a lot of symptoms, or maybe soiling, which then might be increasing risk of UTIs. And so we see a lot of bladder and bowel existence together, though there might be other reasons. There's girls who maybe have giggle incontinence or incontinence with exercise. And again, there's always more reasons as to why. And sometimes there are more congenital reasons, or there may be more, neurological reasons or neurodiversity that might be linked in there. But those, I'd say, are the most common things we see presenting, which, as you say, once they start young, then habits form or things. We don't deal with it that well as well. I'm sure you see this in clinic. I see a lot of adults. The reason I was quite passionate to treat kids is I see a lot of adults are like, well, I've had this since I was 4. And you just think, oh gosh, if we dealt with it better at 4, maybe we wouldn't have got to such a persistent position in your 20s, 30s, 40s. So, I guess that's what I see.
Yeah, and I think that it's quite hard in the paediatric world, because the diagnostics that we have, at least in adults, it's very different in paediatrics. And I think there's not the same kind of level at the moment of detailed investigation, and so it's quite hard to get the right diagnosis and the right access to the right treatments. So I think that's a massive area actually in paediatrics to really focus on.
And is there a sense of almost normalizing that kids have bowel bladder issues, which maybe means that some of these things aren't handled as well? I'm curious actually, Claire, when you said we don't deal with it as well.
I think it's very hard as a parent to sometimes know when does it become a problem? You know what I mean? And I think we have a real problem, if I'm really honest, in our whole approach to potty training or gaining continence.
Right.
No other developmental process does a child learn in 3 days, right? You don't go on a walking program to walk in 3 days. The child naturally learns through exploration, getting it wrong, falling over, then learning. But with potty training, it's like there's this real expectation that you're 2 1/4, the nursery says you're ready to go, and you stay home for 3 days and you nail it.
Right.
And to me, as a parent, I've got 2 children who potty trained completely differently. There is no one way of doing it. So I think my feeling is that our whole approach to that sort of bladder and bowel health is, but then parents don't really know. It's no parent's fault.
No.
And then maybe children do get constipated, but we're not then managing it in primary care particularly well. That's quite well known that it's not maybe dealt with 100%. Don't get me started on schools and children not being able to go to the toilet when they need to go to the toilet. I mean, I've talked to my kids about that so many times. So I think it's tricky. Then the parents are like, well, if they're wetting their bed still at 7, is that a problem? When do I go help? And then they might go and ask for help, and then it's medication, but they're worried about medicating their children. So I guess that's what I mean. It's like this snowball effect. And I just think if we could actually educate more on kind of, I guess, what we're trying to do, bladders, bowels, normal, how can we support, how can we detect early on, when is constipation a problem, when is it not? I think we could be more preventative.
Absolutely. And in terms of, because I guess maybe your average listener wouldn't really make that easy link between constipation and bladder issues. Yeah, could you explain that a little bit?
Yeah, absolutely. I mean, essentially, I think constipation is also quite a term that's not massively understood in the sense of and there's obviously a broad range. But really what we mean by, I guess, more severe constipation is a child not being able to open their bowels for many, many days. I mean, really, if they're not going for a bowel movement every other day, we should start to be thinking what's going on, or at least every third day. But if they're going days and days, that's a problem. Now, see, so the rectum is not really a storage area. It's mainly a transit area. And the bowel is a smooth muscle, so it can stretch. So if that then is filling up with stool, that's getting bigger and bigger and stretched. And for some children, you can get what you call megarectum. This can also happen in adults. Now, that is then sitting on top of the bladder. But then this can also lead to what we call overflow diarrhea. So a child literally having stool leakage, having no idea, often in the underwear.
Right.
And also we know that then the link of that to then getting UTIs, and it's like not their fault. They literally have no awareness because they're so overstretched, they're not getting the same signals as we might to go and open their bowels. So having something big sitting on the bladder can obviously affect their emptying, can also make them need to wee really frequently because they've got something basically sensory-wise saying your bladder's full, even if it's not almost full from the inside, it's sort of being pushed from the outside. So there's like the UTI element, but also then the frequency element. And then all together, that can start to then drive more bladder symptoms.
Yeah, we had a really interesting conversation with Gilly Bond and Elise Day about just how sensitive and kind of overlapping the nerves are in that area.
Right.
And that this concept of even cross-organ sensitization, right, where because you're feeling something in one, or something's happening in one area, you're more likely to experience it in another area.
Yeah, exactly. That concept of that what we call pelvic organ crosstalk is exactly what you describe, where you feel you have distension in one organ in the pelvis, you feel symptoms in somewhere else. And the link with infections is very interesting, actually, because people often think that it's purely some kind of external contamination from fecal incontinence or something that then goes into the bladder. But actually, there's a lot more evidence kind of looking at and showing a little bit that there's a lot of internal translocation of bacteria.
Right.
And so if you do get a distended rectum or colon, pressures building up there, that natural microbiome is internally also translocating into the bladder, triggering infections. And so that's why constipation is a real big factor when it comes to infections.
That's really interesting. So I remember reading a paper years ago on the vaginal gut microbiome axis, or the gut, all of those words, and I think brain was in there as well. But to that point, that the biome in the bowels, as you say, Sachin, that then impacts the biome in the vagina and the bladder.
Yeah. And I think we're seeing more and more. We're just so early on in understanding the microbiome, aren't we? But I think we are seeing more and more research coming out showing that these microbiomes really interact.
So interesting. And so then just in terms of like normal bladders, is there such thing as normal, and when does that start to stray?
It's a good question. People often, when you see a lot of patients in clinic and talk to them about their bladder habits, it's quite interesting how different people are. And people often say, well, what's normal? Like, I'm going this many times, is that normal? And I'd say that, there's a rough guide that we always say, okay, normal is between, you go to the toilet maybe between 3 and 8 times a day. But actually, 9, 10 could be normal for someone. I would say normal is a bladder that you don't really think about. So, as long as it's not disruptive for your life, you're not having to plan out where toilets are, you're not worried that you're going to leak urine, it's not kind of control, you're not thinking about your bladder in that way, then that's a normal bladder. But as a rough guide, we would say kind of normal frequency during the day is 3 to 8 times, nighttime maybe up to once, but it really varies depending on age and medical conditions and fluid behaviour and different things like that.
It's a quite big variation, really, when you think about that, isn't it?
I often say, we can tell you what is normal, but what's bothersome for you.
Yeah.
Because some people are not bothered, and that we can't make that a problem for them.
Exactly.
Whereas other people are really bothered. And I think that's where there's such variability, in the sense of why does someone experience pain like that rather than pain like that? Or, we might examine someone and think, crikey, how are you not feeling that? But they don't. And then someone else, you're looking for something and they feel it hugely. So there's just such variability in humans. But I think it's, we need somewhere to work from.
Yeah.
But then we need that individual to work out for themselves what bothers them.
Yeah. So in a hypothetical case, somebody has had a UTI and that changes how they're experiencing their bladder. The UTI seems to go, but then what they're noticing is they still have this increased frequency. So where they were going maybe like 6 times a day, they're now going 12 times a day. I'm really curious how you might approach that if that was someone coming into your clinic, Sachin.
Yeah, it's a good question. It's very common, first of all, that scenario. We see it very commonly. And I think there's a lot to unpick because in the past, a lot of people used to say, okay, well, you've had an infection and this is just the after effect of that and you just got to wait it out and things improve. But understanding what's actually happening in the bladder, I think is quite important. So a lot of people will have one-off infection and it goes away and then they don't feel anything after that. Some people will have an infection and then end up in this situation where they are going more frequently afterwards for a period of time. And the question then is that because there is some ongoing irritation in the bladder, there's some infective element that's not fully gone, and that's why they're having some ongoing symptoms? Or is it because the bacteria have been cleared, but that process of having that infection and that inflammation in the bladder and the after effects that's triggered on bladder nerve sensitivity or the brain's response to the bladder sensation is heightened? Or is it that there's a separate pelvic floor mechanism involved that's been affected by that period of pain and inflammation that's now propagating the symptoms? So I think it needs a bit of a detailed kind of assessment to work out which of these things it is, because there's a few different reasons why someone might be in that scenario.
And how would you go about helping figure that out with somebody?
Medically, the first thing I do really is try to see whether there is some ongoing inflammatory element in the bladder. Because if there is still an ongoing trigger, then it is very hard to manage other aspects of pain or frequency until you've really got rid of that irritation. And so the thing I mainly do first of all is a lot more detailed analysis of the bladder, whether it's urine or bladder tissue or something to understand whether there's ongoing inflammation and bacteria. And interestingly, a lot of patients do have actually ongoing bacteria that if you treat, symptoms do get a lot better. So I think that's the kind of thing I prefer. It's important not to miss, I'd say, early on, because the longer that goes on, then you start to get these more chronic changes in the bladder, and then it does become more difficult to treat. So I think, assessing urine with more detailed tests, with microscopy or more extended urine samples can be helpful in a proportion of people with specific symptoms to really try and direct the treatments a bit better.
Fantastic. And I want to explore some of that testing with you in a moment when we explore a little bit more about urinary tract infections, because I know this is a big area. In fact, I was really shocked when a few years back I found out that urinary tract infections are the biggest infection next to a common cold, which is mind-blowing because I don't think we really hear about it very much, but it's so common. But just going back to what you mentioned, Sachin, around like pelvic floor changes, Claire, you must see that as well.
Yeah, definitely a lot. And it's a tricky one sometimes because it's sort of like chicken and egg, because sometimes patients, they might come in and be like, I've always had a weak bladder, which I always have to educate is not really the bladder that's weak, but it's the concept of they may have always been a little bit more frequent. And so again, for me, it's always going like pre the start to see if we can understand. But I guess the common things we would see clinically from a pelvic floor perspective is if you imagine really urgently needing a wee or frequently, the natural habit of the body is to try and hold and stop. So, the pelvic floor is a skeletal muscle like any other muscle in the body, and it will respond to do the job it needs to do. And so often people will then present with what we would call increased tone, where it's like the pelvic floor is sort of a bit switched on all the time. It's in that sort of like, I need to be alert because I might have to go all the time. And obviously any muscle that is kind of switched on all the time is not as functional and useful, and therefore can, and equally if there's a complex with the pelvic floor and the urethral sphincter, but then if that's sort of switched on all the time, it can then almost be difficult to fully empty or difficult to initiate or difficult to relax. But it's also quite scary to do that because they're trying to stop these symptoms that are making them stressed and feel worried. So it's a lot of education on the mechanism, understanding what that individual, understanding the why, and then working out how we can help them to sort of retrain that muscle and that behaviour. And it can sort of create this sort of feeling of urethral irritation. We'll have a lot of people who have increased tone being like, I feel heaviness, I feel pressure, I feel discomfort. But it's a bit like in your neck, like if you've got muscle tension, you often know about it, and it can create headaches or other ongoing symptoms. So that's clinically what we would normally, and then we would support them in working out how to then downtrain, retrain, and improve pelvic floor function.
And I'd love to touch on that element of, the impact of these symptoms then. Like you say, it's really stressful to be like, something's not right. And what you were saying before, Sachin, about having to orient your life around the toilet maybe and being super aware. I'm curious how that role of, the stress and impact of anxiety of these symptoms show up in your clinic, and how you both respectively work with that part of it.
Yeah, that's something we see very, very commonly. The people who are suffering from bladder conditions, like you say, it takes over their lives. It's so debilitating, often in disrupting sleep, affecting going out, socializing, their relationships. And so by the time they come to see me, or they may have seen a few other specialists along the way, and they've tried so many things, and symptoms have been going on for so long. And that's when they're really then understandably getting to this point where they're so stressed, so anxious or stressed by the symptoms. And I think there's a few different aspects to that, whether it's worry about whether there's an underlying cause that's been missed, or concern about why treatments haven't worked so far. We see that a lot. Identifying that is really important. That's where then I rely heavily on, so I work with other physiotherapists and psychologists who are really good at kind of addressing that. And I think that is definitely key, yes, with the medical side, but that is really important, I think, in trying to give patients the best long-term results is having that kind of combination of treatment to address that.
I mean, I think it's creating space for the emotion a lot of the time. People are like, I'm so sorry for crying. And I'm like, no, everyone cries in this room. Just come on, let it out. You know what I mean? It's like, first of all, I think it's acknowledging that it is stressful, that it is anxiety provoking, and all of that is valid, because I think, as you say, it can be such a long journey to go there, and they may have not felt heard by a number of people. They may have almost started to feel like, I'm making this up, or I should just be better now. And that you can hold that quite heavily. So I think creating space, allowing emotions, and saying that all of this is valid, and we actually need to get this all out on the table so we can then piece together where we move forwards from here. I always ask, what's the biggest fear? Or what are you struggling with most? And often there is something deeper that they haven't voiced that we can then either acknowledge that we should investigate further, or we should think about how you can get support for that, or actually, I just needed to say that out loud, and now we've talked it through. I think for me, a lot of the work comes into that. I mean, the stuff that we're really passionate about working together on is that sort of, I'm feeling it here, but it's connected to my nervous system, it's connected to my feelings and emotions, and as you say, to every part of their life. And I think when you start unpicking that, that's when the change really starts to happen. And for me, it's then saying your muscles behave, I mean, especially the pelvic floor, are heavily driven by emotions and thoughts, and I can talk about research and studies with them that we've seen that occurring. And I think when you start to understand that, okay, this is responding because also what's going on here, and this talking that's happening all the time in my body, you start to be able to shift and move forwards. But it's doing it in the right way, and it's making sure that they feel their experience is real. I know that's 100% real, even if you're being told the tests are negative and all that sort of stuff. What they experience is real, and we want to help try and make life feel better.
Yeah. I often, talk with people about this easy dichotomy that our brains can fall into when you are experiencing something physical and there's not clarity on the structural thing that's causing it, or the precise etiology of it. There tends to be two reactions, or two dichotomous reactions. One is there's something that's gone missed, to your point there, Sachin, about what we're not finding, which can then leave people super helpless because they're like, I need somebody to help me find this because I can't. Or this is me, I'm doing it, I'm too anxious, I'm putting too much pressure on myself, or, whatever it might be. And on either side of that spectrum, it just means that people, either they have way too much pressure or they are so disempowered. And I think that psychoeducation that you're talking about there of helping people see that interrelatedness has such a destigmatizing effect that allows people to engage a bit more multidimensionally with what's going on.
I think that's a good point. I think stuff can be very binary. Do you know what I mean? The test is positive or it's not positive. And then it's like, well, if it's not positive, then why am I experiencing this? And I think you sometimes get patients coming in who've maybe had a recurrence of symptoms. Oh, what did I do wrong? Was it that one glass of wine I had for my birthday or whatever it is? And, I always say, life, this is not binary. It's not A or B. It's like so multifactorial. And actually leaning into the almost discomfort of that can actually be incredibly freeing.
Absolutely.
That there is so much that's playing in, and we could probably hunt and we'll never find 100% one reason. But it's a hard place to get to.
Absolutely.
Because I don't think we're really wired like that, and I don't think our healthcare system is really wired like that.
Exactly. People are keen to find, there must be something wrong, and you need to find it. If you can't find it, it's just because you haven't looked hard enough.
Keep looking.
Yeah,
it's so true.
And let's go down that route in the context of urinary tract infections. This is such a big area, so I'd love to get your expertise, Sachin, on, well, first of all, maybe let's just start off basic-ish. What is a urinary tract infection?
So urinary tract infection, or UTI, is, as you said, it's one of the commonest infections. And essentially what it is, it's classically a bacterial infection of the bladder, classically, but it could be the urethra, it could be the kidneys. But it is essentially the process where a bacteria invades into the bladder and then triggers this inflammatory response. And that combination of having a bacteria and having that inflammatory response is what we would then call a UTI, a urinary tract infection.
And so for most people, ideally, it can get treated quite quickly with a course of antibiotics. I think the standard course is like 3 days maybe of a particular kind of antibiotic. But then for some people, they might get recurrent urinary tract infections. And I'm really interested in your perspective on the terminology here of like recurrent urinary tract infection and then chronic urinary tract infection, because I know there seems to be some controversy. Are they different things? Are they the same thing?
Yeah, that's a good question, because actually no one knows for sure. That the term of chronic UTI we'll talk about in a minute is, I'd say, relatively new, and still undefined. And so that's why it's so difficult. And so recurrent UTI, the standard kind of definition of that is someone who is having repeated infections, at least 3 in a year, but in between times doesn't have any symptoms.
Right.
So completely asymptomatic, no symptoms in between, but then they'll have isolated episodes of urinary tract infection where they get the classic symptoms and the bacteria is found that fits with that. Now, chronic infection is slightly different. And this is where we think that some patients have persistent bacteria in the bladder, that the bacteria were never fully cleared. So maybe the antibiotic course was too short, or for some reason they're more susceptible for these bacteria, the bacteria are more aggressive, or for some reason they haven't cleared the bacteria fully. And so then this person has persistent symptoms with intermittent flare-ups that we think are due to a persistent bacterial source. And we use things like extended testing or urine testing to see inflammation in the bladder as a signal that there may be a persistent bacterial source, and then we would call that a chronic UTI. But there's a lot of overlap with chronic UTI and another condition called bladder pain syndrome, and with pelvic pain, and there's so much overlap with these conditions, and there's no ideal diagnostic test that says, well, just do this test and that will tell you it's this condition or that. And like Claire said earlier, it's so much overlap.
Yeah.
Even if someone gets an infection, there's so much overlap with other conditions that then develop as a secondary effect. It's quite hard to isolate, but I say essentially, a recurrent infection, you have isolated episodes. Chronic, you have persistent symptoms, but with periods of flare-ups.
And so, by that definition, would what people call an embedded infection, that would be a chronic UTI?
Yeah, exactly. So the theory is that these bacteria, and there's good evidence for recurrence. So 50-60% of patients who have a single UTI will then develop a recurrence at some point within a year. And so a lot of studies from America years ago showed that these bacteria, when they get into the bladder and they invade into the bladder cells, they then stay in the cells and form these, what we call quiescent reservoirs. So they're just lying there dormant.
Right.
And the theory is with embedded infection that these bacteria that are there persistently, they learn to live there, they become part of the bladder microbiome, and then they'll randomly flare up and
Right.
cause symptoms. And so that's the kind of premise on which embedded UTI, chronic UTI, comes from, and some of the diagnostics we use are based on that principle, and then the treatments are really targeted to those bacteria.
And can I ask you a little bit more about the testing? Because in our episode with Melissa Kramer from Live UTI Free, she was talking a lot about people experiencing recurrent UTIs and having the dipstick test in the GP and them saying, well, there's nothing there, and how much of a problem that can be, because we know, I can't remember what the statistics are, maybe you know, but how non-sensitive those dipstick tests can be. Could you tell us a little bit more about the testing?
Yeah, so the urine testing, the classic thing is that if you have symptoms of UTI, or you think is a UTI, you get a urine dipstick done. So you give a sample of urine and you put these little sticks into it, and you wait a minute or so, and the reagents on the dipstick, if there's infection, you get some change in the colour, and then you can kind of get an idea of whether there's infection.
Yeah.
And the two classic things people look at on the dipstick are white, what we call leukocytes or white cells. So that's just a sign that there's some inflammation going on in the bladder. And another thing called nitrites, which is a sign that there's some bacteria there that is breaking down one of these enzymes and causing nitrites. Anyway, there's these two things we look for. And someone can have an infection and only have one of the two. Someone can have an infection and have both, or someone can have an infection and not have either of those,
Right.
For so many different reasons. Because the dipsticks are not that accurate, really. It's a rough signal, but it's not a kind of an accurate test you can really rely on. Typically, when people get infections, they might drink a lot of water to try and flush it through, or take anti-inflammatories, and all of those things will affect the dipstick result. So then often the testing is sent off for a culture. So it's sent into a lab, and hopefully the lab will analyse and say, yes, there's this many thousands of bacteria, therefore there's an infection. But that's also quite limited, because the standard testing that we use around the world has a set cutoff threshold of the number of bacteria that you need before they'll say, yes, it's an infection. So if you have enough bacteria above that threshold, then they'll say, yes, this is an infection. Whereas if it's just below that threshold, then it will come back saying, no, there's no infection. But the way those thresholds were developed years ago is not the same population of people we're talking about now. So they were really developed in pregnant women who were having kidney infections. It's a completely different type of UTI. Whereas a lot of women with bladder infections, the kind of classic UTIs, often it's a much lower level of bacteria that will cause symptoms. And so that's the limitation of some of these standard cultures, is that they may come back saying there's no infection. But if the person has classic symptoms of infection, which they often do, that's a much better judge that probably there is something infective going on. But you just need to look harder.
So ideally they get a dipstick test, but even if there's nothing indicated there, it should be sent off for these further tests in a lab. And even at that stage, if nothing comes back and they're still having symptoms, there should be further investigation. Yeah,
I mean, it's very interesting, actually, that the guidelines changed slightly now, in that people are recognising that the standard testing is not that accurate. And so now, if you go to your GP with classic symptoms of UTI, suddenly come on, irrespective of the urine test, the guideline is that you would receive a course of antibiotics, because we know that actually the testing's not that accurate. And if someone has classic symptoms, that probably is what it is.
Yeah.
And then you can see the response to the antibiotic in terms of symptom improvement.
So even getting an antibiotic is kind of an indicator of whether there's an infection or not, potentially.
Yeah, so for a lot of people, that's the only good marker that, okay, they've got symptoms and they've got a good response to antibiotics, and therefore there must be some infective element.
Claire, I'd love to bring you in as well, because you must see a lot of people who've had a lot of urinary tract infections and have gone through this process.
Yeah, I mean, I think that's gone into detail I've never ever thought about, but I think that's what you hear from women. They're like, but I've got symptoms and I'm being told it's nothing. And I think that's one of the most confusing and most disempowering things. And, you know, like all of medicine is like, you don't treat the scan, you treat the patient. Do you know what I mean? We've all seen chest x-rays that look like this or like that. And then the patient, you're like, is that the same? Do you know what I mean? So it's the same thing, you know what I mean? I think that's where I think the big voice that women will say is I felt really dismissed. And I think again, I don't ever want to point fingers because everyone's following the best that they can do. And ultimately we have these tests for a reason. So it's very natural to then say, well, you haven't got an infection. This is showing that you don't. Very hard as a woman when you're like, well, I've definitely got symptoms. Where's, you know, that sort of then it's in your head. You're making this up. It comes from. So I think it's an imperfect system that we're trying to work in of how do we improve that. Often, you know, I think 3 days isn't enough for some women, especially if they've taken a long time to present. And then, so you know what I mean? We're treating the same one individual with the same approach, but maybe the story is completely different. So hopefully that will change. You know, I think a lot of it comes to education. You know, everyone, obviously the primary care is where a lot of women are presenting. I mean, I don't know what you feel about women buying these antibiotics online, because I know that you can do that a lot now. And I'm wondering if women are getting missed because they're kind of doing it themselves, but they're not actually being assessed. What do you, it's
a great point. And that's a great point. Yeah, I suspect so. Because I'm seeing more and more women who come and say, well, I couldn't, or they couldn't get an appointment with a GP, or it's hard. And it's just much easier to go to the chemist and get a course. And you're right, maybe like you say, they're not getting an assessed or they're not getting the urine sample done early on, then it's hard to find the cause later, or maybe it's not the right diagnosis. And so I think it's pros and cons, isn't there? I think it's obviously there's a UTI is such a common infection, and the reason it's set up like this is so that GP practice is not overloaded with what we call uncomplicated or simple UTIs. But at the same time, is that driving these other issues? Hard to know.
Hard to know, yeah.
I actually didn't realise that you could go to a pharmacist and get antibiotics without going to the GP.
Yeah, certain things now. And things like vaginal oestrogen, you can fill out a questionnaire, and if you fit, you could go to Boots and get it. So there are certain things, and I think, you know, it's good in the sense of they're trying to reduce barriers. As you say, like, we know there's long waitings, there's a lot of pressure on primary care and GPs, or then women presenting to A&E when they shouldn't be there, and all that sort of stuff. But yeah, again, it's an imperfect system because we'd love to have that assessment and make sure that our clinical management is appropriate for that. But will we ever get that? I'm not sure.
Hopefully. We're doing our best. I'm curious as well, you know, going back to this idea that people might have in their head of who are the sorts of people that are impacted by this. My first question is, do you see that there are common times in one's life that people tend to get a UTI? Do they coincide with certain things, certain ages?
Yes. I think so. So, you know, the commonest or the classic is the perimenopausal lady who has maybe suffered on and off with the occasional infection, but then leading up to the menopause, it might be even a few years beforehand, but definitely around the time or afterwards, they start to get a much higher frequency of infections, and that it typically is linked to hormonal levels and estrogen levels vaginally, and so that I think is definitely one peak. And the other peak we often see is in women who start to become sexually active. Sometimes that can be a trigger for infections or an initial infection that then leads to some other events, whether they end up with some pelvic floor hypertonicity or other problems like that. So I'd say those are two kind of real classics. In men, it's slightly different. In men, it's rare to see it in younger men, unless there's some anatomical problem. But classically in older men, as you get prostate enlargement or you know, incomplete bladder emptying, we tend to see then an increased kind of incidence of UTIs.
And is it true, because UTIs tend to affect women much more than men, is that because of the length of the urethra, so it's harder for the infection to travel up, or is that a myth? That's what we're always taught. Okay. That's what we're always taught, that it's the short length of the urethra compared to men. Yeah. So it's easier for bacteria to get in. Probably the anatomy of the urethra being so close to the vagina, and we know that there's a microbiome vaginally around the anus and in the bladder, and so probably there is some link with that. So that's probably the likely reason is that these anatomical differences, short urethra in women, and being so close to the vaginal and rectal area compared to in men, is probably why there is an increased risk. Just the way that you said that's what we're being taught makes me think, do you have other ideas or no?
Well, we don't. Nothing proven.
Okay.
Nothing proven. But I think it's just hard to know if that's definitely the case. Like I was saying before, is that we think that, or the classic teaching is that bacteria start from outside and they get in and climb into the bladder and ascend in and then cause infection, which probably does happen for a lot of women. For a lot of women, that's not the trigger.
Yes.
And you see a lot of women with infections who say, "Well, I've not had sex before," and so it doesn't account for everyone. And I think there definitely are other mechanisms, maybe some internal translocation of these bacteria. We see a lot of people with gut disorders who then start to get urine infections. And is that because of some inflammatory bowel issue that's then affecting the microbiome and then affecting the bladder microbiome? Or is it an immune effect? It's hard to know, but I think there's definitely a few different reasons why.
Yeah. That's interesting to think about, the kind of more internal versus kind of external-ish things that might influence that. I just want to pause here for a moment to highlight just how interconnected physical and psychological experiences are. This is why tending to emotional well-being when you have bladder or pelvic issues is so important. It's also why I'm so proud of the tailored Me Plus support program I've developed with Convatec Continence Care for people using intermittent catheters. This program is designed to support people at every stage of their catheter journey, from those who are brand new to those who've been doing this for years. The Me Plus program integrates the practical side of catheterizing with the emotional adjustment side that so often gets overlooked. We've designed the program using the best health psychology research insights to provide educational tools, practical activities, exercises, and audios to help you process, build confidence, feel informed, supported, and less alone. If this is of interest to you and you'd like to find out more, visit convatec.com and access the Continence Care Me Plus resources. Links can be found in the episode description. What about you, Claire? Do you see people impacted at different times of their life or things going on around?
Yeah, really similar age groups. I think what I often find in my clinics is that sort of bladder symptoms, vaginal symptoms can be one of the first signs of perimenopause. So I think obviously we so classically think of those hot sweats and if I'm fine and my emotions are fine, then I couldn't be perimenopausal. But then I'm like, well, if we just think about it from an estrogen receptor point of view, obviously we know that the vaginal area, vulval area has some of the highest, estrogen receptors compared to your skin or somewhere else. So I think there's an early warning sign, and often I sort of bring it up in clinic to be like, oh, are you noticing anything else? And sometimes they're not, that is just the symptoms that they are. So I think it's sort of sometimes a door in to have those conversations, but I think we're still at, there's a real resistance in some women, and I probably would feel the same as I approach 40, that sort of like, well, I'm not perimenopausal, don't use that word with me. But actually sometimes when we can accept, well, those changes are occurring, doesn't mean that, menopause is around the corner, but actually there will be a real transition of time, and the more we can be proactive about that, even if you don't want to go on HRT, but you might use vaginal estrogen, that could be really good, especially as you say, if there's a history there. I think it is in those younger women as well, where I think there's a massive shift in population now in conversation, but maybe there wasn't as much talk about being sexually active for the first time and what does that look like and what does that mean, or using condoms and having a reaction, or, all those sort of conversations. I still get a lot of women who come into my clinic being like, I've never spoken to someone about my vagina and vulva. Like, I actually don't know where all the holes are. Can we look with a mirror, So I think that education piece, if we can start earlier, and again, not just focus on how not to get pregnant, but also just like how to have good sex and how to look after yourself, and all of those conversations, I think would do a big difference, and maybe another prevention piece. Yeah.
Talking about the estrogen receptors, I've heard a lot anecdotally from women that I've spoken to that the topical estrogen cream actually has seemed to help their UTI issues a lot. Would that be something that you would think about as well, Sachin?
Yeah, absolutely. I think it's a great point you made, Claire, about the early warning sign. That is, it's so true that, you get women in their, early 40s even, no other menopausal symptoms, but they're starting to get more infections or vaginal symptoms or frequency or urgency to pass urine. And it's very... it's amazing how often you use topical estrogens, vaginal estrogens, which are very safe, and symptoms improve a lot. It's amazing how different people feel, and there's so many effects related to that, not just the frequency of infections, but people often say libido's better, or lots of other effects for that. So I think in that group, it's a really good treatment.
I also am interested, going back to your point about it might not just be anatomical things and bacteria getting in. There might be like internal processes and kind of crosstalk across the systems, as it were. And this is where I'm really interested as well, because a lot of time, obviously I see a subsection of clients that are coming for psychological support for these things. But even so, I think people find me because of, not necessarily because they think psychological issues caused my UTI or my bladder pain syndrome or whatever it might be, but because it's taken such a toll. But when we do a bit of an assessment and look at, well, what was happening before, there's a really common theme of multiple things happening, so maybe biologically there was a UTI and they took antibiotics for it, or, there might be something else like a bout of gastroenteritis or something. But then usually these things are coinciding around a time of great social change. Maybe that's role change, losing a job. And then, with all the psychological elements that come with that, the stress, the change in how they're relating to oneself. I'm curious, is that something that you both would see as well? These kind of issues crop up in those contexts?
Absolutely. I always say there's layers, isn't there? And I think what can present as one thing, often the other conditions, as we sort of said, IBS. I mean, is that not one of the most banded around topics that young women might be? I say women because there are a lot of women that sort of present like that. And then they might get a UTI and then they develop sort of some pain with intercourse because maybe it's associated with intercourse and they're worried to have sex again because they're like, every time I have sex, I get a UTI. And so, subconsciously your body's like, well, I don't really want to do that because that leads to that and that's painful. So, as you say, one thing can cascade to another. But, whether you look at the perimenopausal community, I mean, what a time of transition. Often you've maybe got young children or teenage children and aging parents as well. And you're trying to do your career and you're trying to keep down a relationship. Or you may be younger and you're trying to forge a career path and you might be living in lots of places and having lots of new relationships and navigating that. So, yeah, and I think that's where we really have to make sure we never separate the person's biology from their reality because they're completely mixed up together.
Absolutely.
Yeah, I agree. And it's quite interesting actually how, it's such a complex system, isn't it? That actually a lot of people have some kind of stressful life event or something's happened and they'll come and say, I've got a UTI. It may not be a UTI. It might be something else driving the symptoms, pelvic floor or some other cause that's not UTI. They think it's UTI because symptoms overlap so much.
Yeah, so true.
And so I think it's so difficult to work out in that situation. But you're absolutely right. I think those events can have a real impact on nerve mechanisms, on pelvic floor muscles, and a lot of things can then contribute to symptoms.
Yeah, absolutely.
Which people may attribute to UTI, but may not be.
And on that point, I was reading some really interesting research about how they found increased neurotrophins in the lining of the bladder in women with bladder pain syndrome, which the researchers were kind of concluding was an indication of basically upregulation of the nerves in the bladder because of these neurotrophins, which can be a side product of increased stress hormones, which made a lot of sense to me, right? That, your body, obviously we know that that's a very physical mechanism to get stressed, to have sustained stress. Your body's changing chemically and functionally as a result. And then that would have this side effect to shift then the nature of the nerves working in the bladder.
Yeah. And like you say, nerves anywhere in the body it's a dynamic system. They're plastic, so they change. So it's not that the nerves are always the same. If you have some chronic or hormone or something there, inflammation, something irritating the nerves constantly over months and months, or those nerves themselves start to change and become more hypersensitive. And so patients do have then a lot of ongoing symptoms related just to that nerve issue.
Yeah, and I wanted to ask you about that actually when you were talking about the overlap with chronic UTI and bladder pain syndrome. It sounds like that could be a mechanism, right? Maybe there was recurrent infections and then that's changing how the nerves are functioning. Even, I don't know, would it be the structure of them or?
Yeah, exactly. Yeah, I completely agree. I think, definitely think that definitely happens. And that's why there's so much overlap between these conditions. And, it's never, very rarely the case, I find that, that is just one thing in isolation and one treatment works for everything because of all these secondary effects. So one thing triggers something, which then triggers something else. And that's why it needs to be this kind of multidisciplinary assessment of, yes, the biological aspect of it, but also then the secondary effects, the nerve sensitivity, targeting the pelvic floor hypertonicity that often happens then as a result of that. And so some people say, I have some colleagues who say, well, this is just purely infection. You sort of treat that and go hard and forget everything else. But so it's rare I find that works well enough because there's so many other factors involved.
Yeah, absolutely. It's so complex and overlapping across the different systems. And so I'm just thinking about my experience so I started getting, I'd always been prone to having urinary tract infections when I was, I think, even a child and then a teenager. And then I got an infection that didn't seem to go away precisely at this kind of intersection of life when uni was over, things was kind of stressful. I didn't really like the work that I was doing. My social network had gone. So, things were more stressful. I just hadn't really clocked it quite so consciously. But I think there was that process of, yes, that meant that my UTI-prone bladder had some UTIs. But then after a while, I think exactly that process happened where my nerves changed and the infection wasn't there. I was on long-term antibiotics for a while, low dose, but the nerves had certainly changed. And I remember Googling at the time, so this was a long time ago now, and things have moved on and we have got more awareness. But I remember Googling like my symptoms and finding this forum, which was talking about interstitial cystitis. And at the time, it felt like a death sentence because what was in there was like, your bladder's changed, no one knows why, and these are just the symptoms. So and that was such a hopeless moment where I was like, well, am I going to be stuck with this forever? So I would love you to inject some hope.
Well, I that is an interesting point you make because I have a lot of patients who say exactly that. They say they come now saying I've got a chronic UTI, but they say, I went on to the forum, the interstitial cystitis forum, and felt like that was the end. And I don't want to be diagnosed with that because that sounds like a death sentence. Exactly like you say, there's no cure and you can't. But I got to say, I think if you evaluate, if you evaluate the bladder well and you do some of these different types of diagnostics, you really can narrow things down. And even if it's not bacterial, that's fine because there are still lots of treatments that do work well for these other aspects, for the nerve aspect, inflammatory aspect, for the pelvic floor side. So it's just trying to narrow down what the cause is. I used to say to a lot of patients, symptoms do get better. The aim is, yes, it's hard to get it so that it never happens, ever. But the aim is to get them to a point where their life is not being controlled by the bladder. And that often you can get to that stage just by working out the right cause and then starting the right treatments or putting people in touch with the right specialist, physiotherapy, for example, because that can help. That I find really helps a lot.
Yeah, absolutely.
And I like to talk about, like, in the same way that nerves can change to become more hypersensitive, they are still plastic and change the other way. So though it feels very final, the reality is we just need to understand it and not be afraid of what that means. Understand our nervous system as a whole, and as you work, all those bits and pieces that play together. But there's still hope because as much as you change to get to this place, we can change to get you out of this place. And that might take a long time. And I always say, you've got to be realistic of timescales and it won't necessarily be straight. It might be a bit bumpy and up and down and we can't promise it will never happen. But that hope is such an important part of recovery. Because once hope's gone, that's it, isn't it? You just think, well, what's the point? And I think that's where the mental health element comes in. It can feel very hopeless.
Yeah, I think that is such a hopeful thing to point out. If our nerves can change one way, they can change another way. As a pelvic physio working with these presentations, what are the sorts of things that you do in clinic to help people change them for the better?
So I think what we're really looking to is understand that individual's bladder behaviour as it sort of stands today. So we often do a lot of bladder diaries over a few days. And I think that, again, there's for someone who's maybe got bladder pain syndrome, and there is a lot of this, so what they'll experience is, instead of like a normal urge that we might feel on filling of the bladder, it's painful. So obviously it's really relieving for them to go to the toilet. It feels often better. Then that often drives frequency. So then there's sort of this, there's got a bit of a mishmash of what do we approach first. Traditionally, you'll hear of bladder retraining, which is this concept of trying to make the bladder hold for longer. But if that's actually triggering pain and almost dialing up the nervous system, that's not what we want. So in this population, we may do something what we would then call bladder drill, which is actually basically stop trying to trigger the symptoms. It's almost like you've got a bruise, don't keep pressing it. And see if we can get the bladder to empty without pain, which then doesn't constantly cause that sort of neurological symptom of pain, which then maybe then cascades to the reaction of the pelvic floor and everything else. And that might mean that they're going to the toilet incredibly frequently. But once we've sort of stopped driving the pain, we can then extend it rather than constantly. And I see that's done quite badly. There's a really big difference for someone who's maybe got urgency and frequency without pain and someone who's got it with pain. So it's that correct approach. Now, ultimately, in order to maybe do that, we also need their pelvic floor to be functioning better. We also need them to sort of think about lifestyle and regulation, because I always say to women, I can give you a few things to work on for 10 minutes a day, but if you are then, everything is very high stress for the other 23 hours of that day, you're not sleeping well, you're not, you know what I mean? Or there's other things going on in lifestyle. And I also think a big thing I always say to women is, you may not feel stressed. That doesn't mean your body is not stressed, right? I get people, I'm not stressed. And I'm like, no, I know you may not feel it as like a heart palpitations or a panic attack or those classic I'm sweaty or whatever that might be. That doesn't mean that subconsciously this isn't incredibly stressful. So obviously that's not, I don't go deep on that. I would send them to someone like you. But that's where you sort of start to have those conversations to work.
Yeah, it's a really interesting point that actually, and again, I think this is where the trickiness is, isn't it, for that mind-body divide and dichotomy. Don't start palming this off on my stress. This has got nothing to do with that. And it feels like you're going to shove the ball back into their court if you even talk about that role. But, as we know, stress is a physical event in the body, and it has multiple different strands and changes to our physiology. And it can also make us more prone to getting infections because, of the interrelationship with our immune system. But to that point of like, this might involve wider changes beyond the specifically targeted bladder stuff, that can feel quite overwhelming to people, can't it?
Definitely. And I think that's where it's making, I would say we're not looking for a lifestyle transformation here. Like that, I would never expect that of you. I'm not going to do that for myself. So let's be realistic. But I also think then it takes some self-reflection of the individual to be like, are there things maybe I need to change? What could I change? Because there's a lot of like, go and do some mindfulness. Well, when you need to pee every 10 minutes, being mindful is not very easy. So I'm often like, that's not going to work for you. So how else can we create some form of, what does mindfulness look like for you? What does stress management look like for you? And make it approachable. Because I think there are a lot of like sweeping blanket statements that then make someone feel even more isolated. Because there's nothing worse than feeling like, well, I can't achieve that, therefore I won't do it. Or a physio saying, well, you now need to do this 10 times a day. I'm like, laugh in their face. Like, no one has time for that. So it's very important as clinicians that we sit in that person's shoes as much as we can, even if we've not lived that experience, to say, well, and I often say to people, what can you commit to? Because I'd much rather we start there and then scale rather than me say, well, on my agenda, this is what you should do. And I can always tell you what the research says, but that doesn't mean it applies to your life. So it's, you know what I mean? It's this very much two-way relationship that we all have to have together.
Yeah, it's funny on that note of mindfulness. I remember when I was in the throes of having these unexplained bladder symptoms, and I had this such a strong sensation as though I'd been trapped in a car for hours. But it would be relieved to a fraction of a second when I sat on the toilet, and then it would just come straight back. So it was at the very, very worst. And I was going back and forwards to the toilet. I was so unwell. I'd been signed off work for a little while and my mental health was shot. My dad came in and I don't know, I must have been back and forth about 10 times in the last hour or something. And he was like, well, if there's nothing in your bladder, would you not maybe just not go to the toilet and do some mindfulness. And I was like, oh, I was so angry. But you're right. I think it's the blanket statements without the context and the knowledge of like how this might apply. And I always say, you know, we do use mindfulness in the practice, and it depends whether I'm using that term, even that terminology to describe what we're doing, because there's lots of different ways that you can apply it. But certainly it's not the thing that I'm reaching for when people are in high flare, because that's the hardest point to be, let's focus in on this awful sensation and try and make it feel more comfortable. Yeah. And what also, I think what's really interesting is we did a little pilot bladder pain syndrome group for the NHS. I think it was last year or the year before. And it was groups. So early on, I had designed it so that we would do a little experiential practice where we're noticing sensations very lightly around the bladder area. In hindsight, maybe that was it definitely was too soon. But what was really interesting was I'll do exercises like that with people with bowel issues, let's say, or even, you know, chronic pain of other sorts. And people are generally able to like find a different way to turn towards that physical sensation and inhabit it with curiosity. But the majority of people in the group actually had such a strong reaction just by turning their attention to their bladder, huge physical flare-ups, you know, all of them independently. And so I think it really just goes to show this interaction between our brain, the fear around the symptoms and the quick nerve kind of reactivity to be like, no, yeah. don't what are you focusing here for?
But it's like, even if you haven't got bladder symptoms, you know, you get on a coach and suddenly there's no toilet and you're going for 2 hours. Like, I mean, I would never identify as having had bladder symptoms, but I definitely then suddenly needed the toilet.
Yeah.
And I was like, I don't need the toilet. So again, it shows that there is so much interaction outside of symptoms with that. You know, like before an exam, you suddenly need 3 Ws. I mean, do you really? No, you're not biologically getting a stretch sensation, but you are experiencing that. And again, that feeling is real.
Yes.
It's just driven in a different mechanism.
Yeah, absolutely.
Yeah, it's very, very interesting. We often talk about, you may have heard this term, we often talk about brain OAB and bladder OAB. So, you know, it's much more understanding, at least amongst urologists, about the brain elements that trigger overactive bladder rather than the organ itself.
Yes.
And like you say, a lot of the time it's nothing to do with the bladder. No. Bladder's responding normally. It's another cause.
Yes.
It's a central trigger, something in the brain, anxiety, stress, something that's triggering those symptoms. So,
See, I love that. That's really interesting. I mean, I've actually never heard that terminology, but I mean, it's a perfect description. But even, you know, how thinking back to that child-parent relationship of, you know, where do our habits come from? Now, if your parent was someone who always said go to the toilet before you leave the house, even if you don't need to go, you will train your bladder to always need to go before you leave anywhere. So I always say to people, you know, you get so many blanket, it's bad, it's harmful for your bladder. I'm like, let's not get too extreme. But it is also saying that, like, it's habitual. So what you start to do, but it's amazing how, like, an adult has bladder symptoms, the child will often mirror it because they are little, they watch what we do. So I've tried with my kids to very much be like, do you actually need the toilet? If not, we will find one when you need it. Look, if I'm putting them in the car for 4 hours, I'm not stopping in 10 minutes. There's a different conversation there. Yeah. But there is also just kind of trying to normalize for people that where do habits come from, what drives them, and what's coming from up.
That's interesting, that concept of bladder habits, right? Because I talk about that a lot. Well, with people with bladder issues and with bowel issues. And I sometimes talk about the bowel being a bit like a Tamagotchi, where
I love that.
Like, if you're not giving it its food at certain times, it's going to I remember that screen and I was like, I've done everything for you. But I guess the bladder's quite similar, you know, that it gets used to, we toilet at this time. Yeah. And not just in terms of like time of day, but this is our cue to go because we're leaving the house in that case then.
Yeah, or you get back, you see a lot of like key in the door urgency of like, I'm home now, there's a toilet there, and suddenly the bladder's like, I'm ready, and you are running to that toilet.
Yeah.
So we see that a lot in behavioural patterns that can occur, or I don't know, medical professionals are some of the worst, you know what I mean? Like you hold all clinic, and then at lunchtime you're like, well, probably in surgery, and you're like, I suddenly need the toilet but I've not been thinking about it because I'm so busy with my patients, and then suddenly you're like, I really need to go, and I've held for 5 hours, or I don't drink. This is a big one I see with people. They don't drink for hours, and then they suddenly get a pint and they neck it, and then they're suddenly so urgent because they get in this sudden stretch of that like bladder lining, which drives urgency. So this is where small things about how you drink and what you drink can make a big difference. Now, often once you're at a bladder pain point, you can be told not to have spicy food as the full solution, and it's not enough. But there are these small things that absolutely. But we're probably the best holders here. That's what we do all day.
It's true, actually. I think that's a really nice note to, for people listening, perhaps that don't have any bladder or pelvic issues. I'd love to hear each of your perspective of like small little things that we might be thinking about changing habits-wise or behaviourally to look after our bladder and our bladder health.
Yeah, I love that. I think for me, it's just simple. It's just understanding, it is like a balloon. It's going to stretch. You're going to get that feeling. It's telling you something for a reason. You don't need to necessarily go at that first awareness. That's just you being aware, like, I might need to go at some point soon. Look after your pelvic floor. Like, it's not just for people who have babies, it's for everyone. Understand it, understand the relationship a bit better. What we drink matters. If you're just having 10 coffees a day, you're going to pee quite urgently and you'd probably be quite dehydrated. So just, mixing up, but you don't have to cut out all the fun stuff. But it's amazing how you'll suddenly speak to people and they're like, I'm having 3 Diet Cokes and 3 coffees. And you're like, is there any water going in there? So it's just understanding that obviously what goes in impacts what will come out. And
this might seem a silly thing, but actually I've found that a number of men are surprised to hear that they also have a pelvic floor.
Their floors, they're like, why am I here? And their jaws are like, what? And I'm like, let me show you a picture of your pelvic floor. Yeah, absolutely. But that's just an education piece, isn't it? But most women don't also realise, or they don't understand the complexity of it. They just think it's like one little sling of one muscle. When I show them pictures of it, they're like, wow, it's so much more complex than we think. So lots of education work to do there, but really, really important for bladder symptoms, especially in that sort of as men age or maybe go through prostate surgery or something else. We'll support them a lot with that.
What about you, Sachin? What would you say?
I think I think in terms of the fluid intake side, what Claire mentioned, I think that's really important. So I would say to someone, even if they have no symptoms right now, a good way to really protect their bladder health is to focus on bowels and bladder. Bowels have a big impact, and so we're understanding more and more about the microbiome. So eating foods or fluids that maintain a good, healthy gut microbiome and regular bowel habit will also keep your bladder healthy.
Yeah, love that.
Yeah, I think that would be quite surprising to a lot of people, actually, that interrelationship. Yeah.
I was going to say, it's also just really tricky in our healthcare system, though, isn't it? Because you could see, just within your pelvis, you could see a gastroenterologist, a colorectal doctor, a gynecologist as a woman, and a urologist. And obviously, everyone's got their specialism, but there isn't always a lot of, it's rare to hear a urologist talk so much about the gut. That doesn't often happen. And so there might be a lot of bits that I think sometimes are missed because we haven't quite thought outside the organ that we're dealing with, sort of thing.
Absolutely, that integration. So because I meant to do this with you guys earlier and we got into an interesting discussion, but could we tackle, I've got 3 common myths that I see that I just love to get your reactions on because I think that will count for a lot. So this is going back to our UTIs. So a common one is only unhygienic or sexually promiscuous women get UTIs. And I think this also is informed a lot by the concept of honeymoon cystitis.
Yeah, I think lots of women do feel that. I think hygiene of the vulval and vaginal area, again, I don't think is really taught. I think there's a lot of products on the market. It can almost lead to over-cleaning and then impacting the vaginal microbiome or the anal kind of microbiome, and which then causes other problems or thrush or things like that. So, often it's just like, it's not something you've done wrong. You know what I mean? It's just that this is something that's occurred. And yes, keep the area clean with water, but please don't use lots of soaps that are going to have another impact. But obviously when you feel like something's going wrong, you want to do something about it. But body washes are not the solution.
Yeah, completely agree with that. Completely agree. I think it's a really good point about over cleaning. People, it's very rare that it's something to do with a woman's hygiene. But like you say, they feel that way. They over clean, and that can make things worse. So I think it's definitely a myth. It's definitely a myth. It's not to do with that, but over cleaning can definitely make it worse.
Yeah, thank you. I'm glad we hadn't covered that, but that's such an important one. So another one that I hear a lot, it's particularly from people that are trying to figure out, is it a UTI? Is it bladder pain syndrome? If you have cloudy or smelly urine, it must be a UTI.
I think that's not true. I think that's not true. I mean, cloudy urine can happen for lots of reasons. Smelling the urine can happen for lots of reasons as well. So I think it definitely is not always the case that it is an infection. So that those, I would say, are not in isolation key symptoms where you say, right, I've got smelly urine, therefore I have a UTI, or therefore I need antibiotics. It's not necessarily an abnormal thing. But I think it probably warrants some kind of investigation.
Yeah, and I guess touching on your point about not drinking very much, that can also cause smelly. I mean, if people drink a lot of coffee, that can definitely cause smelly urine.
I think, it's actually just teaching from a young age kind of what to look out for. I mean, we've talked to our kids. I mean, they do grow up in a medical household, so not all children will be like, we talk about catheterization at breakfast, sometimes, which is a wild time. But, we talk about colour. And so they actually come up and be like, I think my wee's a bit dark. Maybe I need to drink some more water. And it's just teaching them these small, approachable things, or teaching them like, what should a poo look like, and because you're in your kids' life when they're tiny, very, very for a very short while, and they become more independent, and you need them to be the eyes. You're not always going to be there. And this is not all about parenting, of course, but I think it's an important thing that I think we can model, and the earlier you learn that, it then goes into adulthood, and then you know a lot of these myths aren't necessarily true.
The other one we've already covered actually quite comprehensively, which is if tests don't show an infection, you don't have one and it's in your head. And I think we've done a nice job of busting that myth. Okay, very last questions then. For Sachin, when would you say would be a good time for somebody to seek help or to ask for a referral or specialist clinic? Actually, I've got kind of two questions. But yeah, if they're experiencing bladder issues, perhaps they've tried some first-line treatments, antibiotics, they're still having symptoms, what would your advice be for them?
Yeah, I think that's probably the right time. I think, vast majority of patients with the initial treatments will get better and will not have any problems. But I would say if you're starting to have any of what we call the red flags, so you're starting to see some blood in the urine, or you're having treatments but pain is ongoing or symptoms are not improving, then I think that's the right time to then try and get specialist assessment to really look into things in more detail.
Yeah, that's really helpful, because another thing that I talk about as a health psychologist working predominantly on the psychosocial side of these things, to reiterate, we're not saying that this is caused predominantly by psychological factors, but they play a role. So to help underline that, having a criteria of this is when we need to be going back to your doctors or escalating things is really, really helpful. And, well, this is a question perhaps then for you both. How could people get the most out of these appointments? Because I know that's something that people find really tricky.
With probably similar with Clare, but with ours, a lot of patients have had a lot of investigations or treatments leading up to this point. I think to get the best out of your kind of limited appointment slots, probably the ideal is to keep a good record of all the investigations that have been done so far, all the treatments that have been tried, because often people have had so many different things in it, and it can take up a lot of time going through all of that. At least if there's a good kind of diary of what's happened so far, you can really then get on to what what extra needs to be done.
Yeah. And I guess just to signpost, when we had that episode with Dr. Elise Day, she's created the most comprehensive list of all the possible things that you could have had, and like a history taking form. So I'll link to that as well.
Great.
Yeah.
No, I totally agree. I think, for us as clinicians, it's so helpful when it's there, and I almost check through it. I'm like, just checking this is correct and this is correct, and you've had this and we've tried that and all that sort of stuff. Also, write down any questions or thoughts before you come in, because it's so helpful. When you're in the consultation, you can feel a bit like, oh, there's so much pressure on this time, and I've got this person that I need to ask all these questions. And often people will get out their phone and we'll just work through the questions, and then you really leave feeling like, symptoms may not have changed at all, but you've been heard, you've got a plan. I always say to people, if you've got a plan, everything feels better.
Yeah.
And we need to know what your expectation is. And so the questions and your thoughts are really helpful.
Yeah. There is something super comforting about being heard, of like, these were the things that were on my mind, making them tangible. And then, as you say, having some sense that there's a plan, even if there isn't a plan explicitly mapped out, that there could be, and you've got a bit to start on.
Yeah, totally.
So very last question. So for somebody that might have been dealing with pelvic issues or bladder issues for a while, what does realistic hope look like?
Oh, that's a great question. I think for me, it comes down to understanding your body better as an absolute primary. And I think if you can achieve that as a starting point, and the why of kind of how is this presenting and why am I still feeling this? I think that gives hope as a starting point. And then I think for me, it's then thinking, okay, where are we today? Where would we like to be? Let's break it down a bit and think in small areas of life, where can we? And then have realistic goals. I mean, as physios, we are all about the goals. We're all about what can we do. And it might be really small things. I'll do a lot of like, right, between now and me seeing you again, I'd actually really like you to reconnect with 2 friends that you've withdrawn from.
So great.
Because of these symptoms.
Yeah.
It's actually nothing to do with the symptoms, but actually let's look at the life around you. So when they come next time, symptoms may not change, but they've achieved that goal. Yeah. And actually then they start to be like, oh, well, I actually feel less isolated. And I actually talk to my friend about my symptoms and So I think for me, it's then looking at goals across out of symptoms, but also symptoms. So habits, life, and thinking about it that way. And I find that makes the biggest hope change.
That's such a good point. In the work that I do with people, often, they're in a place where they really don't want to be, and thinking about where they want to be just feels so far off. Yes. And if they create goals around that, it's like, well, that's too big, and I don't believe even that that's a possibility. But talk about this concept of progress goals, which is the sorts of things that you need to be doing to help you get there, which might feel completely unrelated to begin with, like the pain in my bladder and I'm seeing Sheila on Tuesday. But like you say, it actually counts for such a lot, and especially if it can help destigmatize your experience and take off some of that stress. And we know that isolation really does amplify physical issues. So it's wonderful.
So that's where you got to get the education piece right. So they don't say to you, you've got no idea what you're talking about. Like you should know about the pelvic floor anytime I need to text my friend. But then it's giving that context as to why I believe that will be helpful. And I've seen it really work. And I think you get that sort of confidence as you see more patients, that you can be like, well, actually, I've worked with other people like this and these things have helped. But I think hope needs to come in rays of sunshine rather than like suddenly the clouds passing. It just doesn't really happen like that.
Yeah, thank you, Claire. What about you, Sachin?
Yeah, I think education around the trajectory of symptoms is important, because a lot of people feel like, well, you start treatment and things should be then better at some point soon. But I think education around the fact that symptoms do get better, but it's kind of a little bumpy ride. There's ups and downs, but consecutively over time, it's slowly getting better and better and better. I think education around just understanding the time that takes, I think does give people understanding that when they get some flares, it's not necessarily a bad thing, and understanding that they will get eventually to the right place. But it just takes that time.
Yeah, and I do often actually think about the difficulty in being a medical doctor, in that, people are socialized to think you have the treatment and then it is linear, exactly. Whereas I guess with things like pelvic physio even and psychology, people understand that it's complicated and messy. But there's this idea of you take the substance and you should be better, or you have the procedure and it should. So it must be hard for you guys to to have that conversation
Yeah,
too.
it can be. And that's why I think working like we do with, we have a team with physios, with pain psychologists. I think that is really the key.
Yeah.
Because like you say, it requires a lot of different input.
Yeah. Well, thank you so much. I feel like we've talked about so many important things that will be really eye-opening for so many people. So I really appreciate you both coming and sharing your wisdom.
Thank you for having us. It's been great.
Thank you. Cheers. Learned something today? Your brain hasn't finished with it yet. Research shows revisiting new information is all it takes for your brain to start connecting the dots on its own. So subscribe, listen again, and let it do its thing. Thanks again to our partners at Convatec Continence Care. Don't forget to check out the resources and references linked in the show notes. This podcast was produced by Maya Sounds and Music.